for this edition of City Nephrologists Meet. It's quite some time that we have conducted CNM. Post-COVID, this is the first time MMC is hosting this. A warm welcome to all of you. Today we have a collection of 5 challenging and interesting case winners for presentation. May I call upon Dr. Prathiba to present the first case. It is a rare cause of pigment nephropathy. Please present it as a case.
A very good afternoon. I welcome you all to the City Nephrology Meet of March 2023. I am Dr. Prathiba, resident in nephrology, presenting to you a rare cause of pigment nephropathy. A 57-year-old gentleman with no prior comorbidities presented to us with pedal edema, breathlessness, oliguria, red urine, and new onset hypertension, all of 1 week duration. On investigation, his urine analysis showed proteinuria of 2+ albumin and 3 to 4 RBCs. His complete blood count showed hemoglobin of 4.4 grams per deciliter. His biochemistry workup showed serum urea of 180 milligrams per deciliter and serum creatinine of 14.3 milligrams per deciliter with elevated LDH levels. And his viral markers were negative. Ultrasound showed normal kidneys. ANA, ANCA and rheumatoid factor were negative with low complements both C3 and C4. He was diagnosed as a case of rapidly progressive renal failure. Hemodialysis was initiated and he was supported with blood transfusions. Kidney biopsy was done on December 2022. In histopathology, the immunofluorescence, all antisera was negative, and in light microscopy, one of the 9 glomeruli were globally sclerotic. Interstitium is edematous, granular to globular pigment cast are identified in some tubules. Hemosiderin pigment is seen in some of the tubular epithelial cells. On further immunohistochemistry, hemoglobin immunostaining was intensely positive and it was negative for myoglobin. This is the picture of the slide showing granular to globular pigment cast within the tubules and immunohistochemistry showing hemoglobin immune staining intensely positive. So he was diagnosed as a case of hemoglobin cast nephropathy. Working up for the causes of hemoglobin cast nephropathy, the causes of intravascular hemolysis in the tropical countries are snake bite being the common, drugs, rifampicin, NSAIDs, toxins, infections viral like CMV, EBV, falciparum malaria, mycoplasma, bodily injuries like burns, trauma, mechanical red cell disruption in prosthetic valves, autoimmune hemolytic anemias, cell membrane defects, enzyme defects, and transfusion reactions. Going into the pathophysiology of renal injury, due to hemolysis, excess hemoglobin is released into the plasma. The hemoglobin combines with the available haptoglobin and it is taken up into the reticuloendothelial system. The excess free hemoglobin tetramers dissociates to form dimer, which then combines with nitric oxide and is freely filtered by the glomerulus. It precipitates in the renal tubule. It is taken up by the megalincubullin receptor at the proximal convoluted tubule and causes further injury. In summary, the mechanism of kidney injury due to intravascular hemolysis are decreased renal perfusion secondary to vasoconstriction caused by nitric oxide sequestration, direct toxicity to the proximal tubular epithelial cells, or tubular obstruction caused by intraluminal precipitation of the hemoglobin cast. Coming back to our case, on further probing history, he gave history of cola-colored urine which was intermittent, early morning, 4 to 5 episodes 2 years ago, with on right thumb suspicious gangrenous resorption. The patient had anemia, raised LDH and low complement levels. This is the clinical picture of the patient showing suspicious gangrenous resorption of the fingers. On further evaluation for cause of intravascular hemolysis, CMV, EBV, PCR were negative. Smear was negative for falciparum malaria. G6PD activity was normal. Screening for PNH, there was no evidence of decreased expression of CD59. And direct Coombs test was positive. We subjected the patient to further immunohematological workup, where polyspecific direct antiglobulin testing and monospecific direct antiglobulin testing was done. The prerequisite here is the sample is to be collected and maintained at a temperature of 37 to 38 degrees Celsius until the serum gets separated from the clot for testing for polyspecific direct antiglobulin testing and monospecific direct antiglobulin testing. The results were the polyspecific direct antiglobulin testing was positive in 2+ titers. Monospecific direct antiglobulin testing was positive for C3d in 3+ titers, which was significant, and cold autoantibody titers were 1:2048 at 4 degrees Celsius, which was clinically significant. When you suspect a patient to have a cold agglutinin disease, first we go ahead with the polyspecific direct antiglobulin test. If it is positive, then we move on to the monospecific direct antiglobulin test for C3d. If it is positive, then we go to the measurement of the cold agglutinin titer. If the titers are more than 64, then it is consistent with cold agglutinin disease. If polyspecific DAT itself is negative, it is unlikely to be in cold agglutinin disease. And if monospecific DAT for C3d is negative, it can be either a monospecific IgG direct antiglobulin test positive, or there is a possibility of warm autoimmune hemolytic anemia. When the cold agglutinin titers does not match the cutoff for the cold agglutinin disease, then there is a likely possibility of warm autoimmune hemolytic anemia. We went for secondary workup for the cause for cold agglutinin disease. The imaging studies of chest and abdomen was normal. Serum protein electrophoresis showed elevated peak near beta-2 region, and immune electrophoresis showed monoclonal gammopathy in IgM and kappa region. Bone marrow examination was done. Both aspirate and biopsy showed no evidence of atypical cells with tri-lineage hematopoiesis. Patient was diagnosed with a case of primary cold agglutinin disease. It is a well-defined clinico-pathological entity where a clonal lymphoproliferative B-cell bone marrow disorder resulting in an autoimmune hemolytic anemia. The immune hemolysis here is entirely complement dependent, predominantly by activation of the classical complement pathway, resulting in phagocytosis of the opsonized RBCs. Primary cold agglutinin disease accounts for nearly 15% of all cases of autoimmune hemolytic anemias. The homogeneous bone marrow disorder, which was termed as a primary cold agglutinin associated lymphoproliferative disorder, it is found to be distinct from other previously recognized lymphoma entities by forming a nodular B-cell aggregates in the bone marrow specimens. The mechanism of complement-dependent hemolysis in the case of cold agglutinin disease was the cold agglutinins have high affinity to the carbohydrate I antigen on the RBCs. As the blood cools when it passes through the acral parts of the body, the cold agglutinin binds to the RBCs and causes agglutination of the RBCs. It in turn binds to the C1q and activates the classical pathway, which results in formation of C3 convertase. As the blood gets rewarmed, the cold agglutinin detaches from the RBCs, but the RBC remain coated with the C3b. From here, the fate of the RBC is decided. It can be either taken up by the liver, phagocytosed into the liver, or it dissociates from the RBC and leaving it coated with the C3d, which forms the basis of the monospecific direct antiglobulin test, which is specific for cold agglutinin disease. Sometimes, from the step of activation of C3, it may activate the membrane attack complex, resulting in intravascular hemolysis. The diagnostic criteria for cold agglutinin disease are chronic hemolysis, positive polyspecific direct antiglobulin test, monospecific direct antiglobulin test strongly positive for C3D, cold agglutinin titers more than 64 at 4 degrees Celsius, and no overt malignant disease by clinical examination. Serum electrophoresis, immunoglobulin class quantification, examination of bone marrow should always be undertaken to detect any clonal lymphoproliferative disorder. The negative results does not rule out a primary cold agglutinin disease. Coming to the management, patients with cold agglutinin disease should be kept warm and infusion of cold liquids should be avoided. Because all the IgM is intravascular, plasmapheresis efficiently induce clinical improvement in acute situation or when the patient is subjected to surgery requiring hypothermia. There is no role for steroids in the management of cold agglutinin disease. The mainstay of treatment here is rituximab monotherapy. These are the criteria by which patient can be classified as either acquiring complete response, partial response or no response, depending on which the further treatment plan is decided. Patient can also be started on rituximab with fludarabine combination or rituximab with bendamustine combination. The other modalities of treatment like complement modulation with eculizumab, TNT003 targeting C1s, peptide inhibitors of complement C1 or comstatin which blocks the cleavage of C3 have been used in anecdotal cases. Our patient who started on rituximab monotherapy, 500 mg IV, once in 2 weeks, totally has received 4 doses. The current status of the patient is hemoglobin has improved from 4.4 to 10.2 grams per deciliter with serum creatinine of 1.2 mg per deciliter and is non-oliguric. Is currently under nephrology and hematology follow-up. Acknowledgement. My special thanks to Dr. Anila Ma'am, Director Renopath for her slides, and Department of Hematology, RGGGH FMC, and Department of Transfusion Medicine who have helped us in evaluation and management of the cases. These are my references. Thank you.
I haven't really come across a full-fledged form of cold agglutinin disease. We have come across paroxysmal nocturnal hemoglobinuria, other causes of intravascular hemolysis. Actually, I was telling when we were discussing the patient, over a period of 4 decades, this department has seen varying etiologies for intravascular hemolysis, starting from copper sulfate poisoning and falciparum malaria, which you cannot see now, it's not there. Then slowly moving to other causes like, of course, snake bite is one thing that is remaining. The same in terms of the clinical presentation and the contribution to AKI over 4 decades. One disease that's remaining static is snake bite. Again, snake bite, there is one change in the clinical presentation, that's more and more of thrombotic microangiopathy, which we have not seen in the past. Apart from that, other causes, paroxysmal nocturnal hemoglobinuria, I think we have published also from our department. So this is kind of something new. Very interesting. It was a thorough learning exercise for us. And thanks to the Department of Transfusion Medicine, now we have everything. It's a complete department. We have MD Transfusion Medicine course also. They do thromboelastogram and all these tests are available here. The point to note here is that when we refer to literature, even in primary cold agglutinin disease, most of the RBCs, they get lysed in the spleen, they are phagocytosed, so it's a kind of extravascular hemolysis. The intravascular hemolysis and that to this magnitude to cause acute kidney injury is not that common, that's what the literature says. But she had beautiful explanations and all that. And 2 things, they say that steroid does not have any role. That is very clear cut. The better choice here is rituximab. We have to address the lymphocytes, B lymphocytes, and subsequently the plasma cells, which produce the IgM antibody. That is number 1. And the treatment transfusion is discouraged unless the anemia is very severe and unless it is resulting in kind of a clinical impact. That's what they say, because it's self-limiting. How is it self-limiting? Because, as she has explained in the pathophysiology, the prerequisite for the hemolysis to happen is that binding of the C3, the complement component, on the RBC membrane. When there is a crisis, when there is a trigger, when there is an insult, the activation happens and then a lot of complement goes and gets deposited attached to the RBCs. So the system becomes complement dependent, depleted. That is evidenced by the low C3, C4 levels. Once the complement level drops below a particular level, the disease becomes self-limiting. So you have to just monitor the course of the clinical event and then decide whether blood transfusion is required or not. And another point of interest is that, unlike in other situations of hemolysis, where when the disease process is active, any number of transfusions, again it is going to be the same. Sometimes it worsens the clinical situation. But here it is not so. When we give the blood transfusion from a different source, those RBCs are less vulnerable for hemolysis compared to the autologous RBCs, because these RBCs are not coated, not sensitized, not coated with the complement fragments. So these are the interesting points. And we have rituximab, thanks to the government supplies there, and he's on regular follow-up. As she pointed out, I think the disease is not over. This particular episode has come to a kind of remission, and he has to be educated thoroughly to avoid whole situation. I just read in the literature a very interesting point of discussion. Suppose imagine this patient goes in some end-stage organ failure, goes for transplant. What will happen? Because before transplant, the organ that has to be grafted is perfused with cold lysate, cold solution. And what they say is that you have perfused with cold perfusate, but just before engraftment, a lukewarm solution has to be used for perfusion. And you'll be inviting trouble because the organ is so cold, the recipient's resistant. The cold agglutinin, suddenly there can be a spurt of production for agglutinin. Of course, that's a hypothetical situation. It was interesting to learn that. Thank you so much. Any queries?
Is there any HLA association of genetic
No family history.
We have very frequently we do come across that, sir. We have published also. Pardon me? Malignancy has to be ruled out.
Yes, sir. Malignancy has to be ruled out. So we did
One of the diagnostic criteria to audit the primary cold agglutinin is that
to rule out.
No. The point is, can it evolve into a malignancy like MGVS evolves to myeloma?
Then it becomes a secondary cold agglutinin. In fact, whenever you come across a cold agglutinin that causes hemolysis, it's a binary, primary and secondary. You are supposed to rule out the secondary causes, infections and malignancies. Then you have to do these tests and then. Yes, sir, any intrascale hemolysis.